thinking about ways to empower patients in a way that, allow them to have more control over their health, right? And so when we're talking about educating patients in a way where you can activate the care team around them, but letting them know it's like, hey, you don't need to necessarily call 911 for everything, but be able to call your care team. And so there's so many pieces to the waiver that I think I want to be able to highlight, and we could talk for hours about. But I think that piece also is important in terms of being able to meaningfully transform our healthcare system. It does require not only change internally within the four walls of the healthcare system, it also entails us changing our posture in terms of how we have traditionally engaged patients in the system, and engage them in conversations about their own care.
You're listening to the Health Disparities podcast from Movement is Life. I'm Dr. Mary O'Connor, chair of the board of Movement is Life and co-founder and chief medical officer of Vori Health. Hospitals and health systems can play a big role in addressing healthcare disparities in our nation. It's the focus of our latest podcast series. And today we're going to zero in on a statewide health equity initiative that is first of its kind in the nation. Through a historic 1115 Medicare waiver, Massachusetts hospitals have made a commitment to come together with the state to embed equity into the foundation of their operations. To learn more about this exciting initiative, I'm joined by Izzy Lopes, Vice President of Health Equity for the Massachusetts Health and Hospital Association. Izzy, welcome to the Health Disparities podcast.
Thank you so much for having me, Mary. I appreciate it. Such an honor to be here.
Oh, I'm really excited about this one. So let's start with a little background. So last year, Massachusetts hospitals really began this nation-leading commitment of addressing health disparities through this Medicare waiver. And the effort is being spearheaded by your organization, the Massachusetts Health and Hospital Association, in partnership with the state of Massachusetts. So can you tell us a little bit about what this is and what some of the key points and goals are over the 5-year span of this project?
Yeah, certainly. I'm happy. I love talking about the waiver. So I'm really elated to be able to come here today and to share kind of the progress since we started and began this journey, which continues. So the 1115 waiver is geared towards Medicaid patients. It's a $2.2 billion effort over the course of 5 years. And of that pot of money, our hospitals actually tax themselves. And the other portion of the money does come from the state and the federal government. And the aim of the 1115 waiver is to really seek to advance equity across various domains, of which there are 3. And so I'll briefly go over those domains. And within each of those domains, there are subdomains. And again, the aim here is to advance health equity so that the patients that are served across the Commonwealth can achieve optimal health, because that is ultimately what we want. And so with regards to the domains, and so this speaks to what our hospital systems have to do. And so as I'm talking about the domains, just kind of have that thinking in your mind of, okay, the work and the effort that goes into being able to or having to achieve some of the things that I'm going to mention within these domains. So we have, for example, collection of demographic and health-related social needs information of our patients. It also entails ensuring equitable access and quality. So this entails kind of looking at disparities, for example, and seeking to close those disparities by developing meaningful interventions that speak to the patient population. So this requires, needing to know who the patients you serve are. And then the last area of focus being capacity and collaboration, which speaks to kind of external relationships and partnerships with entities outside of the 4 walls of the healthcare system, and also entails, kind of how do we treat patients in a way where patients can feel valued, feel like they're being treated courteously, and feel like they are being treated with dignity as well. And so, as I said, across these different areas, these core areas, there are subdomains within each of those. And with those domains, our hospital systems have various milestones that they have to effectuate on over the course of 5 years. And there are measures of success attached to those. And again, this is with the aim of, being able to advance health equity, and make sure that, all of the patients that enter the hospital systems, and again, this is focused on Medicaid patients specifically, are able to achieve optimal health. So this really does entail an intentionality on the part of our hospital systems that I think is unmatched in many ways. An intentionality and a will and a drive and a desire to do this work, because it does also entail, the ability for a hospital system to look at internal processes and workflows and procedures to really ask the question, are we serving our patients in a way that is going to achieve outcomes that, is going to result in a patient being healthy as defined by the patient? And so I think that is critically important to keep in mind. So there's this kind of internal work that's happening, a mirror, if you will, on the hospital that they're putting to themselves to say, let's review our policies and processes to make sure that, we are continuing to serve our patients in a way that, will promote and advance health equity.
Yeah, Izzy, let's take a step back because I just realized that, some of our listeners may not be as familiar with Medicaid, right? And understanding why do Medicaid patients have more health disparities? So shares, I could ramble on as a surgeon about that, but I'm going to ask you the question. Top 3 reasons why Medicaid patients have greater levels of health inequity compared to others?
Well, there are a lot of issues at play or reasons at play, I think, here. I think that, in terms of, economics, and patients being able to have access to adequate care. Medicaid patients, tend to be those that, their income levels are not necessarily conducive to, getting access to certain types of care or certain levels of care within the hospital system. And so I think that, the economics play a role here in terms of looking at, the Medicaid program, and the provisioning of care to Medicaid patients. Also, we know that, in terms of looking at, behavioral health issues and different comorbid conditions, there tends to be an increased percentage of, comorbid conditions within the Medicaid populations. And so, we're talking about, I just mentioned kind of, families, individuals that, in terms of their income level being, a certain percentage of the federal poverty level, for example, and kind of being under that level, and that being kind of their entry point into the Medicaid system, as well as, some of the things that, health challenges people might be contending with their care with regards to, behavioral health issues or, substance use disorder. And, a sundry of other, medical health conditions as well. So there is a particular, profile, if you will, in terms of the Medicaid patient and them needing kind of, a more specialized touch, if you will. And again, you're gonna hear this word of intentionality being mentioned. And I think that it's really important to keep in mind that, although the waiver program is focused on Medicaid patients particularly, that we are really looking at this program in general as essentially kind of the litmus test or exactly the test that will pivot the Commonwealth as we think about the health ecosystem, and people being able to look to our program to identify the areas of promise and the different ways that we have made strides so early in the program. So I think that it's important to note that, being able to have this program that is focused on patients that are in need of service, and have such complex issues, and then taking into account kind of the cultural nuance into play, right? And so another component of the waiver is being able to assess, the language needs of patients, and being able to be mindful of, the cultural, background of a patient, to be able to develop these interventions that are really targeted to particular populations. And then I also don't want to lose sight of the fact of, LGBTQ plus populations, those that are differently abled as well, because that is also part when we're talking about, equity, being able to target those populations as well. So it really is, looking at, patients that have traditionally have had disparate access to the healthcare system, or for whatever reason are contending with different care issues, healthcare issues, behavioral health issues, and trying to really meet them where they are in order to get them the best service, and make sure that their needs are met.
That's great. And of course, one of the challenges is basically that traditionally Medicaid payment to hospitals and clinicians is less than what a hospital or a surgeon or doctor would be paid if that patient was insured through a commercial plan, right? So that's also, and as you said, the patients tend to be lower socioeconomic status and sicker, right? So all of these factors really combine to create this access problem. And they have fewer personal resources to help them navigate their health challenges.
Very true. Very true. And I think another piece of this is being able to, as part of the program, is thinking about ways to empower patients in a way that, allow them to have more control over their health, right? And so when we're talking about educating patients in a way where you can activate the care team around them, but letting them know it's like, hey, you don't need to necessarily call 911 for everything, but to be able to call your care team. And so there's so many pieces to the waiver that I think I want to be able to highlight, and we could talk for hours about. But I think that piece also is important in terms of being able to meaningfully transform our healthcare system. It does require not only change internally within the four walls of the healthcare system, it also entails us changing our posture in terms of how we have traditionally engaged patients in the system, and engage them in conversations about their own care.
Absolutely. Just one more background question. How long has the 1115 waiver been in effect? When was it created?
Yeah, so thank you. So the waiver program officially kicked off or launched in January of last year. That's considered to be performance year 1. And as I stated before, it's a 5-year program. So we're currently in performance year 2. But conversations about the waiver and the realization that initiatives such of this magnitude was essential and critical. Conversations had been happening prior to 2023. And I want to say they began in earnest in 2019, even those preliminary conversations about, how can we really, propel change forward, hence the structure.
All right, now I'm going to ask a really important question. How in the heck did you get the entire state of Massachusetts? No, I'm serious, right? Healthcare systems tend to be competitive with each other, right? They're all seeking the patients that have the best insurance that's going to provide them the most, financial resources to help them with their mission. And I'm very careful here not to demonize hospitals and healthcare systems, because we know that a lot of services they provide are not reimbursed, and that they need to basically shift funds from service lines that are more financially positive to those that aren't, right? No health system makes money taking care of children, right? So I'm a little bit, I try not to demonize them, although I am plenty critical of them in other areas. So, but honestly, what an incredible achievement. Like, to get all of these healthcare systems that are essentially competitors to work together.
Mm-hmm.
Can you
So,
give us
yeah.
some background on that's like a miracle?
Right. And I think, I really enjoy getting this question when I do get the question posed. I think it would be a surprise to folks that I think if you were to be a fly on the wall, Mary, in our learning collaborative calls, which hopefully I'll have an opportunity to talk a little bit later about, but it's basically our support structure. We have a support structure, a very intensive and rigorous support structure in place as part of the waiver work to support our hospitals as they're kind of seeking to achieve these various milestones over the course of 5 years. But essentially, and not to kind of oversimplify things, I think that, being able to corral folks around kind of this vision, right, of, okay, we know that things aren't really working well, right? And particularly, we know that things are not working well for people of color, for those that are differently abled, for LGBTQ plus patients, for example. And so how do we move the needle, a communal move the needle forward? So I think that, being able to, across the system, have that will, right? Have that will to know, and that acknowledgement of like, this is critical work. And we are only successful if we band together, band our kind of that collective brain trust, what we've learned and some of the challenges, and to really try to identify in a collaborative way how we can solve some of the pressing issues that plague healthcare today, with regards to these persistent and prevalent disparities that exist in communities of color, for example. And so I think that, to answer your question, it really does, it did consist of, this level of, again, intentionality to come together to say things have to change. We have to operate in a different way. And then also realizing that, the patient being central to this, that everyone has this will, this intrinsic will and desire to make sure that, we are being very thoughtful about how we are providing care in a way where people really feel like they are being supported in their health. And again, this is not just relegated to the four walls of the health of the hospital system. We have to talk about the care or the healthcare ecosystem. So again, this requires partnerships outside of the hospital, right? And so it really is a focused effort where the hospitals have come to an agreement and understanding this feeling of like, we have to do this together. We're in this together. It's really critically important to our success as a Commonwealth for us to be a healthy state. And what does that entail? And so these are the conversations that happened, prior to the official launch of the waiver, that I think it's important to note. But really, it is this kind of sense of we-ness, that we are in this together, and that this should be a focus.
Well, so I think what I'm hearing is that, well, sometimes change occurs because of external forces, right? Like a new regulation. And so a hospital system has to make a change because that's now the law or the regulation.
Mhm.
What I'm hearing from you is this was really more of an intrinsic, more externally driven change where the collective mindset was we need to improve the health of our state,
Mhm.
right? We will all benefit collectively with improved health outcomes,
Mhm.
and let's come together to collaboratively make this change. We're
Mhm.
stronger together. We're more effective
Exactly it.
together.
That's exactly it. That's exactly it. And I would definitely say, in summation, that captures it very well. Yes.
So let me ask you, the MHA uses the term anchoring equity to help frame this mission. And I'd like you to explain to our viewers what you mean by anchoring equity.
Mhm. So I love the visualization of the graphic that our tremendous communications team developed as part of this branding initiative called Anchoring Equity. And so you just have this vision of an anchor, essentially, right? And how an anchor essentially has this mooring property, right? It has a grounding property. So I think it speaks to kind of the importance of this foundational importance of equity, and how that is essential foundation and the framework that guides, the work that we do, and the various initiatives, I think, that are related to kind of healthcare, improving, eliminating, disparities that exist. And so if you have this vision of this anchor in your mind, it really is kind of a grounding principle that equity really has to be central to the work that we do, and the realization that, for us to be able to eliminate these disparities, right, and to close these gaps that are kind of historic and systemic in many ways,
Yes.
that we really have to have this mooring principle, this grounding principle, and understanding that equity is paramount to the work that we do, and it's critical.
I love that. I mean, I already had the visual in my head, and it's just a great way. I love that. It's a great way of framing it and really driving that message that it's so foundational, right? I mean,
It is.
it just has to be if we're going to improve health in our communities, in our states, in our country. And I often I often come back to what we just lived through with the pandemic, where if there was one lesson I hope we learned is that we are all together. Affluent communities cannot isolate themselves from less affluent communities. If one community is getting sick, everybody's going to get sick.
That's exactly right. And that's
You know?
exactly right. And the example of, the pandemic, COVID-19, I think is top of mind for a lot of folks when they're talking about collaborations of this magnitude. It's, you think about, the forces that came together and banded together, with the pandemic, faith-based institutions, and, the community-based entities, and, hospital systems, with the realization that we really have to come together and figure this out. To make sure that, people continue to be healthy, and that people can get, adequate testing, and get, vaccinated, and educate people as well. So it really did take a village in order to spread that message of the importance of taking care of oneself during that time, and being able to address the disparities that exist with COVID, with communities of color particularly. So I think that's important to mention in terms of the collaboration piece, and hearkening back to that time, because that's exactly, what we're seeing today.
Right. So take us through a little bit about how you're actually operationalizing this. I know that your team has several calls a month with hospitals and healthcare systems where you're discussing the ideas and advancing the work.
Mhm.
So can you give us a couple examples of those kinds of calls and the the progress that you've made on some specific projects?
Yes, definitely. So I think that, as I mentioned in the beginning, we have these learning collaborative calls. It's part of our overall waiver support structure that we have in place. And we launched our waiver support program last year in June, and we were able to have 17 calls last year. And these calls continue, and they will continue for the life of this initiative. And so it really is an opportunity. It's a forum where our members have an opportunity to come together based on the various subdomain topics, of which there are 10. And so they are aligned to the subdomain topics. So there's calls specifically on health-related social needs screening. There's calls on RELD, and I'll say the acronym. I'll say out the acronym, which is race, ethnicity, language, disability. And then we have the SOGI component, which is sexual orientation and gender identity. So we have these conversations on a regular basis. They're about right now 3 calls a month taking place, and it's an hour where we kind of give an overview of what the expectation is for that particular subdomain. And we either have speakers come in to talk, outside speakers. So we've actually partnered with outside entities and organizations as we realize that, we need other players involved, right, to have these conversations with our members, and to be part of these conversations as we seek to move the needle forward with regards to equity. And so essentially we ask discussion questions, there are opportunities for breakouts, but it really is a forum for them to come together to share promising strategies, to share some of the challenges that they're experiencing, whether it be kind of discussion about workflow and what's the best, individual on the care team to ask, this question: who's the best individual to kind of enter this information into the EMR? So it's really kind of getting into the operational pieces, as you were kind of mentioning, to be successful and to be able to have that, again, collective brain trust on this call, where you have folks on, different places of this journey, right? That are able to speak to their experience and to share, this is what has worked for us, or conversely, here are some of the challenges and pain points that we experienced, because some of these changes require, change management, on the level of the hospital, of the conversations with staff to say, okay, this is why we're doing this. This is why we're changing the workflow. This is why we're doing this new thing. And I think that is so central to a lot of the work and the conversations that we're having, is to be able to let our members know and to share strategies on, how to get staff to be engaged, meaningfully engaged in this process, as part of, everyone being, moored or anchored to the mission and the goal of anchoring equity and advancing equity. Also, the education on the part of patients of what does our posture need to be? How do we need to change as an organization, as a system, in order to meet the needs of our patients? And so being able to have those conversations and leverage the patient voice vis-a-vis focus groups or the patient family advisory councils, for example, is so critically important. But the learning collaborative calls are essentially like where that happens, that ideation, that brainstorming, that, hey, you did this and I'd love to hear a little bit more. Can you share that resource? And this kind of speaks to what you were asking before, of, this kind of never being seen before, this level of partnership and collaboration, because we have members who are actively sharing information and sharing resources and tools that they've used in this setting. So I think it's been so tremendous, I think, to see the journey, the evolution of the journey, and the trajectory that our hospitals are currently on, because everyone is in this place of knowing and understanding and acknowledging that this is such critically important work, and that this is truly historic. And so everyone has really corralled around this overall goal that the waiver seeks to achieve.
I want to go back 1 minute for something you mentioned in the beginning, which is because I'm not sure our viewers will really understand why this is so important. You talked about collecting the information. We use the term demographic information, but that's like for those that aren't so familiar with that, that's information about the patient, right? Mm-hmm. Their background, socioeconomic status, resources that they have, family support. And I think that most of our viewers would think, well, don't you already do that? I mean, don't healthcare systems already do that?
They do, yes. Oh, I'm sorry, I didn't.
No, but we know this is a varying degree, right?
Right.
So speak to the importance of this standardization, right? That we're going to agree to collect this information on everybody, mm-hmm. and why that helps so much with anchoring equity, with advancing the mission.
Right. Thank you so much for that question. I think it's a great question. And I think that, it speaks to the ability, a hospital system's, ability to tell the story about the patients that they serve. So, a lot of people sometimes, patients, feel that, information is just being collected on me. I don't know what you're going to do with this information. There's a feeling like it's being collected just for collection's sake. And that is the furthest from the truth. And again, there is this purposefulness that is involved in this data collection, right? Of being able to have an understanding of your patient population, to then be able to develop interventions, where you're noticing certain patterns. So if you have a certain segment of the population where you're realizing, hey, people are experiencing issues with food security, or transportation, and you're seeing these trends, then you have the ability, once you kind of see these patterns, for example, then you have the ability to kind of strategize, to say, who do we now need to partner with in order to address that issue, right? And so a lot of the question asking also lends itself to the forging of these really meaningful and robust partnerships and collaborations outside of the healthcare system. And again, I'm going to always make these allusions to kind of, advancing health equity, anchoring equity does consist of this broader we, right? That is not just relegated. It's not just solely on the responsibility of hospital systems, right? This really is a cross-sector, collaborative type of effort, and it does require those partnerships to be forged and developed and to be cultivated in a meaningful way. So being able to create those linkages and identify who are the entities outside of our four walls that we can kind of tap into to support us to support our patients, the collective R with this work, and then being able to then internally, once we are noticing these disparities or certain patterns with certain members of the population or certain segments of the population, being able to develop those interventions, right? And again, the intervention development could entail also looking at internal processes, procedures, and protocols to see how in what ways are those disaligned to what we're seeking to do, right? And so it does require kind of that internal work of looking at the operational structure, if you will, of the hospital system, the conversations and the partnerships that happen outside of the hospital system, and also kind of the data collection piece and the data analysis piece to be able to tell a story over time about certain things that are being noticed by virtue of these questions being posed. So it's not just food security and transportation. It's questions about intimate partner violence, for example. It's about kind of what are some of the behavioral health needs or connections that we can make for you out in your community. And also being able to ask about one's identity, I think, is really important in order to tell a story. And so I think that if you're thinking about the data collection piece in aggregate or as a whole, it really is important work in order for us to understand how we can curtail and eliminate, some of these trends that we're seeing with certain populations that are served in the healthcare system.
I love the point that you brought up about how important the partners are outside of the hospital system, because having been an orthopedic surgeon for decades, right? There's only so much an individual clinician can do. There's only so much even a hospital or health system can do, right? And really, I always say that we have a sick care system, and we need a well care system with wellness rooted actually in the community.
Mm-hmm.
And so this effort of pulling in other resources, this much broader concept of this health ecosystem, I think is critically important. So kudos to you all for working on that.
Right. And I think this is it's such a monumental effort, and it just speaks to the passion and the level of engagement, I think, on the part of our members. They're the ones that are doing this work and are thinking really critically about how they can best address the needs of our ever diversifying population, which I think is just an important conversation to have. So where historically maybe perhaps there's been times where partnerships have not been made or connections outside the hospital have not been made. And not to say it's happening now. I think that it's just, in terms of talking about the 1115 waiver particularly, I think that, hospitals are really, kind of seeking ways to either re-engage former partners or to look at, ways to creatively address some of the issues that they're contending with within the hospital system. And also, this desire to create this idea of this, neighborhood health home, right? Like this, being able to engage partners in a way where patients can be served within their community, right? So that there's services that can be engaged and activated, again, outside of the hospital system. But a lot of that does entail, kind of this partnership and these partnerships and these collaborations.
And just to maybe oversimplify this, but the way that I think about it, so you can cross-check me here, is the 1115 waiver allows an organization, a healthcare system, to take funds that would have traditionally been restricted to things like direct patient care, right? The patient coming to see the doctor or the nurse, and use those funds to help support these more broader health ecosystem efforts. Is that in a nutshell how it supports this?
Yeah, so I would say the funds from the waiver are they're being leveraged by the hospitals for operational purposes. So to just to make sure that kind of the internal engines continue to run, but part of that is kind of thinking about staffing levels and how to leverage and position staff in different ways, how to you know look again, looking at the policy and the procedures and to think about, okay, what is needed? What do we need in order to be successful with this work and to be able to address the needs of the member population? I'm always saying our because when we, we at MHA, we are constantly using those words or the verbiage because we see it as like this is us as well. Like you're not in this alone. Hospitals, like it's an us, it's a we thing. So, but yes, I think that the intention is that the funds from the waiver will be kind of rolled back into the hospital system to not only continue sustaining operations, but to also, if we think about the kind of places for innovation, the opportunities for innovation, and where technology can be leveraged in a different way. So whether that's using kind of kiosks to asked where patients can use those kiosks where you're kind of going to this kiosk and you're being asked questions on health related social needs as another way, for example, to get this information. And so hospitals are constantly in this place of creatively identifying solutions that speak to their patient population, which is in many ways unique. And so even segments of the patients, within their overall patient population, and their recognition that there are patients that require different touches. You're thinking about language considerations, or those that who are deaf or hard of hearing, and so it really does require like, what do we need to do now? What do we need to change? What do we need to purchase? What do we in order to be able to address the needs of all?
Yeah, that's great. All right, so we'll close up with two final questions. What are a couple of the top metrics that you're tracking that you will know at 5 years you've moved the needle?
I would say overall, there's this, there's the continuous quality improvement piece of this work, and our hospitals, identifying quality measures where they will, they identify the quality measures and they basically stratify the information that they're getting based on that those quality measures. And again, telling the story of the patient population to kind of figure out kind of what are the interventions that need to be developed in order to address those particular gaps in care, for example. And so what needs to be changed? What are the conversations that need to happen with the patient to have them engaged in the care? What are the conversations that need to happen with staff so staff understand the why, right? And so this is a conversation that is continuous. But that is one of the areas in terms of the quality measure and looking at disparities across particular quality measures. Also, we have disability competency training, and being able to be culturally sensitive to different populations. I think that the training piece that is involved with the waiver, I think we cannot understate that, because we know, like with a change of this magnitude, and again, it being over the course of 5 years, but there are various milestones that have to be achieved over time, that our hospitals are actively working on. And so the training component is so important in terms of understanding the staff that you have. And are staff equipped? Are they resourced? Yeah. Are they skilled in order to meet the needs of our patient population? But again, that requires one to know the patient population, hence the data collection piece, right? Yeah. And so the data collection piece is also another critical component of this. So again, me alluding to the RELD SOGI, the race, ethnicity, language, disability, sexual orientation, gender identity, seeking to understand the health-related social needs of the patient population, kind of what the disability accommodation needs are of the patient. And again, going back to this place of what is the picture being told? What is the story that is being shared right now? As we look at as a hospital looks at their patient population to then develop these interventions and to actively close these gaps in care.
So, final question. So, I'm asking, have other hospital associations in various states reached out to you? I mean, I would hope that other groups would be interested in learning from your experience and trying to basically reproduce the program that you are leading.
Oh, definitely. So I think that we are in. So Oregon has a waiver that is very similar to ours as well, and so we've been in. I know that in the nascent stages, we were in conversations with them about some of the metrics that they were leveraging and some of the kind of the specifications around their waiver. And so I know that there's been internal conversations there that actually continue. And there are different forums where, that I know that I sit in, for example, as part of, MHA being a member of the American Hospital Association. And there are monthly calls that take place that I'm a part of. And so anytime that I'm sharing information about the waiver, which I love to yell from the rooftops and share broadly with as many people as I can, because it's something that, brings us such pride, I think. But constantly being asked questions or being, pinged after the fact of, hey, can I pull your ear? Can we have a conversation? Because we're seeking here to do X, Y, and Z, and we'd love to hear what your experience has been. And so that definitely has happened. We had, a few hospital systems reach out to us last year to kind of just have those type of conversations, which we're always, happy to have, because I think that, critical to this work is being able to spread, right, and to share promising strategies and practices, and where we can do so and have another system adopt those or spread them themselves. I think that is part of this work, right? This is all part of the effort to anchor equity, and we love to hear those stories as they occur outside the Commonwealth.
Yeah, that's wonderful, Izzy. All right. I'm going to ask if there's any last comment you'd like to make to our viewers, because you're doing such incredible work. It's very inspirational.
Right. I would just say that, this truly has been, I think, for me, someone being fairly new to MHA, and having been doing this work for quite some time. I won't date myself, but it's been a while. And to see the evolution as we're having these conversations about advancing equity, and what does that mean? What does that truly mean? And, especially now with kind of, conversations around DEI, and DEI being kind of at the forefront and on a national scale of just kind of a magnifying glass being put on DEI, of to know that this level of work is happening, and there's so many partners and collaborators that we work with at MHA that I think just constantly inspire me, and I feel like our members, and being able to be in the room with them where they're having these conversations, and I can just sit back and just listen and chronicle a lot of the conversations that they're having, and the stories that they're telling, because I think that it's important to know that behind the percentages that we share, right, of disparity with this population being this or that in the form of a percentage, there are people, there are faces, there are families, there are individuals behind those percentages. And I think that, being able to have that understanding that we're talking about people, right, at the end of the day, because it's easy to be in those spaces where, these percentages and the data and the statistics are being tossed about. But it's another thing entirely to be in this setting and to be doing this work with such committed individuals, where they're telling the stories about, a patient and the benefit gleaned from some of these the things that are happening on the ground level at the hospital systems by virtue of the waiver, and to hear those stories and those advancements has really been really powerful.
Well, this has been fantastic and fascinating, and I'm going to share with our viewers that you can learn more about the Massachusetts Health and Hospital Association Health Equity Commitment at
Yes.
the link in our show notes from today's episode.
Thank you so much.
I want to put a quick plug in for our upcoming annual summit. Registration is now open. This year, the Movement is Life Summit will be in Atlanta, Georgia on Thursday, November 14th and Friday, November 15th at the Whitley Hotel in the Buckhead area of Atlanta. You can go to our website to register, and there'll be more information. And of course, that will also be included in the show notes. So I want to thank our amazing guest, Izzy Lopes. Thank you so much for being with us.
For having me. Thank you so much. It's been such a pleasure and an honor, and we appreciate the opportunity to share our story with your listeners and your viewers. So thank you.
You're very welcome. So this brings us to the end of another episode of the Health Disparities podcast from Movement is Life. I'm Dr. Mary O'Connor. Until next time, be safe and be well.